Let's talk about heart caths. A left heart cath, or a selective coronary angiogram, is a very commonly performed procedure in cardiac cath labs, and it gives us a way of directly assessing the blood supply to the heart. I'm Phil Dattilo. I'm an interventional cardiologist. I've got somewhere between 15 and 20 years of work in the cath lab, having done thousands of cases over that time. And I think a lot of times the cath lab remains a bit of a mystery. And so I wanted to make a bit of a video showing how things look in the cath lab. If you are a patient who is planning on having a cath, this may help take away some of the mystery as to what might be going on in there. Now, this is going to cover one very specific case. It's using radial artery access. And so there are very different flavors of what you might get in the cath lab, different procedures, different access points. But this is, these days, probably the most common access point for the most common procedure that you're going to get in the cath lab. And I have to thank my patient who allowed us to film the procedure. We've been through a couple of procedures together already. And so it was very kind of this person to let us film. So let's get to the video. So up in front of me, there's an ultrasound machine, and there's a dark circle that's, if you look close, pulsatile. I'm trying to point it out with the red arrow here. So basically I have the ultrasound probe in my right hand. I have an anesthesia needle on my left, just giving some lidocaine to numb up the area. And then once the area is numb, we're going to take a very small needle. It's called a micropuncture needle. And using the ultrasound for guidance, we're going to take that needle right on top of the vessel and puncture it directly. So try and minimize any trauma to the blood vessel. This is a very reliable way to get access. Once the needle's in, we get blood flow back, and then we put this small wire, which is 18/1000 of an inch, and we switch that out for a sheath. This is what's called a 6 French sheath. 3 French is 1 millimeter, so this is a 2 millimeter inner diameter, a little bit bigger than that, maybe 2.2 millimeters in total. It's also got this, what's called a hydrophilic coating, so as it gets wet, it becomes slippery. This really helps keep it from getting stuck in the vessel. One of the very rare complications of this procedure is that the vessel clamps down on the sheath and it needs surgical removal. Fortunately, knock wood, I've never had that happen. In addition to having the hydrophilic sheath, we also use this cocktail that I'm about to give, which has blood thinner, heparin, and then some vasodilators, nitroglycerin, and verapamil. And these just kind of relax the vessel as much as possible and keep it from clotting off. Now, in this procedure, we're using what's called a Rampart lead system. In any cath lab, there's going to be some sort of leaded protection because fundamentally we're using x-rays to take the pictures. So we have to protect everybody in the room. Now the patient does get exposed to radiation. That's the consequence of this type of test. Usually it's not so much that it's going to cause any sort of trouble, but for those of us who are working in the lab, we're in there day in, day out, potentially a lot of exposure, so we wear lead. We have lead shields that you'll see. And then with this particular setup, it's actually quite nice. We put this lead paneling essentially around the patient, sort of at the level of the pelvis or maybe the abdomen. And then we can stand to the side without wearing any lead. Our lead suits, mine probably weighs 20 pounds. I kind of like heavy lead. You can get them lighter, but still you're kind of wearing lead all day. So this system is quite nice to take some of the load off the back and the hips. So anyway, we get the lead around the person who's having the procedure, and then the next step is we're going to take first a wire and then a catheter. Catheter is over the wire, and we're going to run that basically up the arm. So typically we're using the right radial is where we're going to be getting access. Going to take the wire up past the elbow, past the shoulder, and then down into what's called the aortic arch. And the aortic arch kind of looks like a candy cane. So going down to the short end of the candy cane with the wire, and then over that wire we run our catheter. Catheter is just a long straw, and we can inject our contrast dye through that catheter. The contrast dye is opaque to radiation, so as we inject it, it looks dark. Now you'll see me kind of moving my hands. I'm just moving the catheter to get it into the proper blood vessel. In this case, this is the right coronary artery, and it's going to be what's called a dominant right coronary artery, which just refers to the territory of the heart that it supplies. About 2/3 of people have this type of vessel. This vessel has previously been treated with a stent, and there's just a smidge of what we call restenosis or re-narrowing within the stent, which had been an issue in prior years. So we were attuned to this going into it. In fact, it was one of the reasons we were going in to look. And so in some views, what's happening, the camera is kind of moving around the patient, so you get different angles. The heart's at an oblong angle, it's an oblong shape. So we move the camera around. In one view, it looked like, well, maybe that's 40-50%. In another view, it looked more like 10 or 20%. And so what we do is we have what's called an FFR wire. So this is a very clever tool. The wire itself has a pressure transducer. So we can measure the blood pressure downstream of a blockage in question and then upstream at the same time, and we compare them. And we basically have metrics to say, downstream compared to upstream, is there a reduction in flow? And if there is it significant enough that we should be putting in a balloon or another stent? In this particular case, fortunately, the test was essentially normal blood flow, so that little bit of restenosis isn't causing any trouble at all. Hopefully that will continue to be the case in the future. So now we've looked at the right coronary artery, we're now going to look at the left coronary artery. And we have different shaped catheters for different arteries and different anatomies. We have quite a selection, but there are a couple standard ones, and those are the ones that we use in this case. What's called a right 4 and a left 3/5. And so basically, again, we just kind of torque the catheter a bit, connect it up to the pressure line. So in addition to injecting contrast with this setup, we're also flushing the line and measuring pressures. And so that gives us a bunch of information all at once. We're also keeping track of the EKG at the same time. So in addition to that, there's a circulating nurse who's watching oxygen saturations and making sure the patient's comfortable, giving medications as needed. Most of the time for these procedures, patients are awake. Some very awake. Some people even do it without medication, which is fine. Typically, the vast majority of people are going to get just a little bit of Versed and fentanyl at least. But we're frequently having conversations, talking back and forth as we're doing the procedure. Good news is it usually is not painful. Of course, with anything, there are situations where the worst thing that can happen in a procedure like this, from a pain standpoint, is getting spasm in the arm, in the blood vessels. Sometimes the blood vessels are kind of small relative to the catheter size, and the vessel clamps down. That can be painful. We treat that with medications, and usually it's not too big a deal. So now we've finished with our coronary angiogram. So we've gotten the pictures of the coronary arteries, and we threw in that FFR measurement just to make sure things are good with the stent. And now we're going to do what's called, well, in our parlance, you'll hear the words VGram, left ventricular angiography. So the catheter is going to go now inside the left ventricle, the left chamber, the big pumping chamber of the heart. This allows us to look at the overall heart function, see if any specific parts of the heart are not moving normally. So overall, we have nice results here. Procedure took maybe 10 minutes start to finish so far. Now it's time for the sheath to come out. So what we're going to do is put a pressure band around the arm. And so that's going to exert pressure on the radial artery after the sheath comes out. In this case, there's a balloon, basically an air-filled bladder that exerts pressure. There are different systems. Even in our lab, we have a number of different ones that we use. But the general idea is always the same. you have pressure on the artery, and you want the artery open but not bleeding. So we don't want to totally stop blood flow to the hand. In rare cases, the vessel can clot off altogether and then can be gone for life. Interestingly, it doesn't usually cause a problem with the hand. It's more just its loss of access. Sometimes that vessel can get used like for bypass surgery. And generally we want to keep things open when they started open. And so this technique, putting partial pressure over the artery in conjunction with those medications that I described earlier when we just got started, those are going to go a long way to keeping the vessel open. Hopefully fewer than 1 in 20 people are going to have any sort of problem with the radial artery in terms of closure or long-term pain or anything like that. So this was a pretty straightforward called left heart cath or coronary angiogram. Hopefully this was helpful to you. And again, thanks to the patient who volunteered to be the subject of this video. And I have to say thanks to my man Jake Musalam, who served as the photographer. He is a wonderful tech in our cath lab, does an amazing job, and seems to be a pretty good cameraman as well. So way to go, Jake. Thank you. So that wraps it up for me. Let's talk again soon.